So I'm happy to introduce our speaker today. Dr. Fanucchi is a board-certified physician in internal medicine and addiction medicine. She provides treatment for opioid use disorder in the UK Bluegrass Care Clinic, in the UK First Bridge Clinic. Dr. Fanucchi's research focuses integrating evidence-based treatment of opioid use disorder in medically complex patient populations. She has presented regionally and nationally on the management of hospitalized patients with opioid use disorder and provides trainings to physicians and other members of the healthcare team. Dr. Fanucchi is also a co-investigator on the treatment team of the Healing Community Study. So let me stop sharing.
Thanks, John. I'm just gonna pull the slides up. Oh, I have to go forward. So since this is a Q&A, please, I encourage you all to participate. We don't have any financial disclosures. Our practice gap and educational needs. There's a gap in the number of people with opioid use disorder receiving treatment with medications who would benefit from it. Low threshold medication for opioid use disorder is a key link between episodes of illness driven by opioid use disorder and effective management of opioid use disorder. And then we will share evidence-based strategies regarding reducing barriers to treatment access, improving access to effective medication for opioid use disorder treatment, and lessons learned from the rollout of low threshold medication for opioid use disorder clinics. We'll identify critical challenges facing patients seeking treatment for opioid use disorder. We already described the treatment initiation process, requirements, and best practices. We described the features and team structure of a low threshold opioid use disorder clinic and its impact on a patient's initiation of treatment. So hopefully today we'll be reviewing some questions around implementing practices to reduce barriers to accessing treatment and procedures and best practices when initiating new patients onto medication for opioid use disorder.
All right, so I'm going to quickly call on people to just kind of introduce themselves. So the first person is Jackson.
Sorry.
Can you hear me? Can you hear me?
Yes.
Okay. Hi, I'm Jackson. I'm a research analyst at the Center on Drug and Alcohol Research. I'm in Fayette County.
Thanks. Abigail? Okay, we'll just move on. Amy?
Well, I'm Amy Longwell. I know there's both of us are on here. I'm the community coordinator for the Healing Community Study in Boyle County.
And I'm her counterpart, the prevention specialist here in Boyle County for the Healing Community Study.
Ashley?
My name's Ashley. I'm a peer support specialist at the Boyle County Shepherd's House.
Andy?
Can you hear me?
Yes.
So I'm Candy Sturgeon. I am the Hill Nurse for Boyd County, and I apologize, my video's off. It's one or the other, hear or see. So.
No worries. Danielle?
Hi, I'm Danielle. I'm the Addiction Medicine Fellow at UK, and I'm working with patients in Fayette County.
Devin?
Hey, Devin Oler, primary care addiction medicine here in Fayette County.
I believe Erica?
Hello, I'm a nurse navigator with the Healing Community Study here in Fayette County.
Heather?
Hey, I'm Heather Donofrio. I'm the community coordinator in Franklin County.
Helen?
Hi, my name's Helen Latta, and I am the prevention specialist for Fayette County.
Jamie?
Jamie Cody. I am the Transitional Care Program Manager here at Bluegrass Care Navigators.
Jennifer Miles?
Hello, I'm Jennifer Miles. I'm the Executive Director for the Healing Community Study, the University of Kentucky.
Jennifer King?
Hi, I'm Jennifer King. I'm a registered nurse with Bluegrass Care Navigators, and we'll be working to support all of our nurse navigators in all the Wave 1 counties.
Joy?
Hi, I'm Joy Clevenger. I'm a licensed clinical alcohol and drug counselor. I work as a social service clinician for Prestonsburg and Pike counties.
Carrie?
Hello, everyone. I'm Carrie Adkins. I'm the Madison County Community Coordinator for the Healing Community Study at the University of Kentucky.
Kayla?
Hi, my name is Kayla. I'm at UK with the addiction medicine team here, and then I also see patients at the First Bridge Clinic through UK.
Kanita?
Hello, my name is Kanita. I am Mina Phillips. I'm a SSC for the Department of Corrections, and I cover Boyle County, among others.
Lisa?
Hi, I'm Lisa Romley. I'm the educational program coordinator for the Healing Community Study.
Margaret?
Hi, I'm Margaret McGladry, and I'm the Criminal Justice Project Manager for the Healing Community Study.
Nina?
I believe I did mine a while ago. I may have walked over someone.
Oh. Okay. Natalie?
My name's Natalie Lowe. I'm the RN for the Healing Community Studies in Floyd County.
Nikki?
Hi, I'm Nikki Strunk. I'm peer support specialist with Spark Ministries, Madison County, Casey Law Advocacy.
Phoebe?
Hi, everyone. I'm Phoebe. I am the HEAL program coordinator with Voices of Hope.
Let's see, Sonia?
My name is Sonia Ross. I'm with Mountain Comprehensive Care Center. I'm with the Addiction Services. I'm the coordinator.
Tim?
Good morning, everyone. My name's Tim Burton. I'm in Boyd County. I also serve in Floyd County as a recovery coach for Voices of Hope.
Thank you. Tom?
Tom Buford. I'm a peer support specialist with Isaiah House and Admissions, and then I serve all over the counties on a volunteer basis, connecting churches, connecting people that are looking for rehab and that type of thing.
Thank you. And then I think we missed Kanita.
Hello, my name is Kanita Thomas. I'm a psychiatric nurse practitioner. I serve Kenton and Pendleton counties.
Thank you so much. Did I miss anyone else? All right. Thank you, everyone.
All right. Thanks. Well, of course, it was forwarding before when I didn't want it to, and now it won't move. Hold on. Oh my goodness. There we go. So just to review a couple of the things that we discussed last week, there are a number of factors and barriers affecting people's ability to get into and stay in treatment. And this was a qualitative study that looked at some of those issues. And if we categorize them, some are personal issues or personal barriers. So an individual may have experienced, may not have had a good experience at a previous treatment facility that was maybe more punitive model. Perhaps they have concerns that they will be required to attend groups and they feel very anxious in a group setting. Perhaps they are ambivalent about stopping substance use or stopping all substance use. They may have schedule conflicts in terms of being able to continue to work. They may have some fears about entering treatment. They may have stigma or have family or friends with strong opinions about medications for opioid use disorder. So, and then of course there are issues. And I'm sure you all could think of some other challenges for in terms of people's ability to get into and stay in treatment. Financial and structural is another category. It's common that clinics may require cash payments, and that's a major barrier for people staying in treatment. They may live a good distance from the closest treatment provider, and they may not have reliable transportation, or the cost of transportation is great. And there may be issues with insurance coverage for medications that makes it challenging. And then there may be some clinic-specific factors that make it hard to access and stay in treatment. The schedule may conflict with the individual's work schedule. There may be waiting lists. They may require multiple counseling appointments, for example, before the patient receives a prescription for medication. If they have other medical problems, they may need to go to multiple clinics to get their various health issues addressed, and that can be a lot of time, money, and transportation as well. And there may be extensive restrictions or rules about attending the program that may be difficult for an individual to meet. So as we discussed, the impact of these barriers is great. So 9 out of every 1,000 Medicaid patients has a diagnosis of opioid use disorder, but less than 1% of every 1,000 Medicaid patients receives medications for opioid use disorder. People in rural counties are less likely to receive treatment than those living in urban counties. And when patients present to an emergency room with a non-fatal opioid overdose, we know that they're at risk of a future fatal overdose. And without medications, certainly without medications. And unfortunately, about 5% of patients presenting to the ER with a non-fatal overdose will die within a year of a fatal overdose. And this is a very young population with a median age of 39. That is a very high mortality rate for that young of a population. So we reviewed what should be included during a patient's first day. Some of those items are a comprehensive assessment and exam, an assessment of risk behaviors, including injection and sexual risks, a mental health history and evaluation, opioid overdose education and naloxone, either distribution ideally or prescribing. And then a urine drug screen and laboratory testing. The laboratory testing may occur within a couple of weeks of beginning treatment and should not be a barrier to initiating treatment. A treatment agreement should be reviewed, and then ideally an initial discussion of goal setting as well as counseling recommendations. So a question came through, what should a client or person assisting a client be looking for when choosing a provider? Can you all provide some suggestions that you might have?
I mean, I think you have to look at those client resources, whether they have insurance, and payer sources, transportation, that type of stuff, some of the barriers that we were talking about. Is that what you're asking here? Because I mean, those were some things that I would want to discuss with somebody first off if I was trying to help them.
Yes, so those are absolutely client specific barriers, and we can talk about those as well. So we can explore some important things to assess from the client standpoint, and then also what would we want to understand from the provider in terms of assisting someone in accessing treatment with a provider. Are there things that we might want to understand about the clinic to help a person decide?
Yeah, sure. I would want to know that. I mean, I would love it if it was somebody that I've personally met through this, and I know that they don't use any of that stigmatizing language or behavior, and like there's not a protocol set up on admission for mandatory tapering and that kind of stuff. Like I would want to make sure those things didn't exist.
Yes. So we might ask, do you have a certain amount of time that people are allowed to receive medication, or do you all require tapers even if a person is doing well? Is the medication time period, is it time limited? Those kinds of things, and those might be concerning.
Laura, Jamie says in the chat, ability to obtain a timely appointment. I think that's really critical, not just an appointment, but an appointment where you're going to get medication. Often there's initial requirements or intakes, and it could be a day or two or a week before somebody can potentially get started on treatment. And then Joy mentions the therapy requirement as well.
Someone's doodling. Yes, those are all really good points. Any other suggestions?
Tim makes a good point in the chat of, are they on the resource guide? Again, a good reminder that those are institutions that have been vetted by the Healing Communities Study and are doing the right evidence-based practices.
Use your tools.
Absolutely, thank you for that. We did ask those kinds of questions in recommending providers on the community resource guides. You might want to ask about the insurances that a clinic accepts, what their practices are in terms of if someone is doing well from an opioid use disorder standpoint, but maybe has maybe they use some other substances.
I like Candy's suggestion as well in the chat, identifying their goals. Are they just looking for, medications for opioid use disorder to get started on, or do they really need primary care or linkage to, Hep C treatment or struggling with a lot of other mental health issues? And so can that provider take care of all those things, or are they going to need to refer you out to another person who's able to tackle those issues?
Yeah.
And Carrie says, I would want to find out how willing they would be to work with me in my schedule regarding appointments. Like early morning hours, later in the day hours, those sort of things are really important as well.
So I think somebody mentioned a specific counseling specialty. I think some clinics may have a particular counseling focus, and that could be something of interest to a client potentially. But generally, if they don't have that specialty in-house and it's a need identified when a person is initiating treatment with medications, then hopefully a referral could be made, and that it shouldn't be a limitation in initiating treatment.
Dr. Fanucchi, this is Danielle. I was just going to say, in considering where you're referring patients, you have to consider, the time commitment. For our particular clinic, it's a pretty large time commitment. So people that don't have flexible work schedules may not be able to do that. And it's been frustrating for many of the clients that come in and want to start and then find out once they're in the door that, hey, I can't commit to all of these an afternoon a week or whatever they're going to do. So finding out how much time and if it's going to work with the client or the patient's schedule is really important.
Yeah, absolutely. That's a good point. Any other thoughts or ideas here? Okay, we can move on. So some of the things that patients are looking for in a clinic are that it's low threshold. So a representative quote is, I can come here anytime. That's especially beneficial when they're experiencing social and financial difficulties, unstable housing or homelessness, inability to pay for transportation to or from the clinic, or incarceration. It's common that we might have clients who are dependent on someone else for a ride, and when that schedule happens to be, when that person's able to give them a ride, may not be predictable. And so flexibility at the clinic and maybe with some walk-in hours is really helpful. Additional points about flexibility: they let you heal however you have to. So being centered and meeting people where they are, not forced to engage in groups or counseling. Patients and providers decide on the best supports. And that there's a focus on harm reduction. So it's viewing slips or return to use as an indicator that that a person is not doing well and that more intensive treatment, more support may be needed, that it's not then treatment termination, because that increases a person's risk for more harm and potentially even overdose death. The same is true for use of other substances. So if someone has an opioid and a stimulant use disorder, for example, and they're doing well, not using other illicit opioids, but there's consistently methamphetamine present. And if they're terminated from treatment for opioid use disorder, then that not only are they still using methamphetamines, but then the likelihood of returning to higher risk opioid use is much higher. And so I see it as a provider as then I'm making things worse by releasing patients from treatment in that setting. We always offer access to harm reduction tools like naloxone and strategies to help people be educated on how to keep themselves safe. If you are going to inject, this is how, let's talk about it and let's make sure that you're being as safe as you can be. Any concerns or questions about those concepts? So the next question is there a way to limit the number of times a person with substance use disorder has to provide their background information? I hear frustration from people with substance use disorder about the repetition of requests for history assessments. Maybe it's inevitable, but is there any way to limit this? So it is best practice and standard of care when you're meeting a client for the first time to review the history. You would review outside records as well, but it's important to talk about it yourself. And I totally understand that sometimes that can feel frustrating. One of the things that can be done in terms of being trauma informed is you can ask permission to talk about sensitive topics, and the person always has the option of saying, I don't want to talk about that right now. Or, the question could be, did something like this happen in your past or in your life? And the answer could be yes or no. If it's yes, we don't have to get into details on the very first meeting if that's uncomfortable. But ultimately, the best way to avoid rehashing a history is staying with a provider in a clinic for a while. And so that's one of the things that, I guess it's another reason why retention is important, is being able to develop that rapport and relationship with the provider over time.
I find that when you're working as a team, this becomes a little bit easier too. So, we're lucky at our UK First Bridge Clinic to have an excellent peer support specialist, social worker and counselor that works with patients, as well as our nurses who will room the patient. And we can sort of get all the information we need when talking together about that patient. And so I don't need to poke and prod on certain subjects that the peer support reviewed, as long as there's sort of clear avenues of communication between the various team members. So just tapping into that team mentality, I think, makes it easier for clients to move through that process in a way that doesn't feel like an interrogation, but more of a conversation.
Any other thoughts or questions or about this question?
I saw in the chat, Amy, your comment, and I don't know if you wanted to speak to it more, but I just thought that was a really powerful comment to say that for, over time and treatment, providing that information became a powerful story the longer your story, and a powerful story the longer in recovery. So that was just a framework that I hadn't seen, and just wanted to make sure everybody saw that comment.
Chris. Yeah, I mean, I get the aggravation of having to repeat it. Thank goodness for me, I was able to stay with the same wonderful provider the entire time that I used medication for opioid use disorder. And she was fabulous. So I didn't have to tell it multiple times, but like as a nurse, like I can understand that. And so for me though, like telling that study or that story in other places, whether it was self-help meetings or whatever, like it just eventually became like a story, and it's kind of a testimony at this point, and it becomes really powerful. So yeah, thanks, Chris.
Thank you for sharing that. So if there's going to be a delay in starting treatment, what do you recommend a client do? So I'm curious what you all think here.
I see one comment in the chat about referral with self-help meetings. I don't know if others have thoughts.
So I think kind of in line with what we were talking about before, an approach is emphasizing safety. So reviewing again, making sure that a person does not have, a person has access to naloxone and knows how to use it, that he or she or they don't use alone, that that they understand that you've talked through, using a test dose, particularly if it's an unfamiliar supply, making sure that they have access to syringe service programs. And if the delay is something very specific, like insurance or transportation, then working with that person on trying to reduce that barrier, helping them link with insurance or other community programs. You can see some things came up in the chat.
Dr. Fanucchi, does anybody use, and this has been, a while back when I was first in recovery, like I worked at a facility that used medication, but they wanted you completely, like, it's a whole nother story, detox before you got on like buprenorphine. But we used like comfort medications like antihistamines, phenergan, clonidine, and stuff like that. Like, is that, I guess you'd still have to have a provider write it, but is that something that's ever even done anymore?
Yeah, it is, but usually not. It's usually with initiation of medication.
Okay.
Daily. I will say, comfort medicines are certainly provided if a person is choosing to go through withdrawal and initiate naltrexone, for example, Vivitrol. And they can help some reduce symptoms, but certainly don't make it pleasant.
Right. Okay.
Yeah. I mean, I think for me, from a safety standpoint, without treatment, without medications, the likelihood that a person will have with opioid use disorder that will continue to have some opioid use, I want to make is high. And so I want to make sure that they're as safe as they can be with ongoing use. But yes, I mean, they would need to see a provider to receive supportive medications. There are over-the-counter things that can be used, like Tylenol, ibuprofen to help with aches and, antidiarrheals, but it's hard to tolerate on your own.
Dr. Anderson had a good point, which is, just trying to close the loop of communication with clients or patients that you're seeing, and they're in a difficult situation like this and might be going through some withdrawal, or might be a little bit of time before they can transition to another clinic that can provide them appropriate evidence-based care. So saying, I'm going to call you tomorrow morning. We're going to check in. We're going to see how you're doing. We're going to see what additional things we can do for you. That's a huge support for, I think, a lot of our clients, and just reminds them that, we're trying to pass the baton off to someone else, and make sure that they're carrying that forward.
Yes. Any other thoughts here? Yes. Tom noticed that people that experience medically or not medically supervised withdrawal without medicine come back in. And this is exactly the problem, compounded by the fact that going through withdrawal like that takes away your tolerance. And so actually that's a dangerous thing. If your tolerance has dropped and you use the same amount or sometimes even less than you had been using before, you can have a fatal overdose. And so that's why medications are so essential, that once the brain is tolerant and physically dependent, it is not something that can be reversed in a very short period of time. And so, but the tolerance and the ability to have a large amount of opioid on board without the breathing suppression, that actually goes away. And so that's what's risky. You said, people don't come back, right? It's also very unpleasant, so that those experiences then are internalized as failures for some people. And so they may feel that they've tried and tried and tried and only experienced programs that do not offer medication. And then afterwards, there's slips, there's relapses, there's return to use. And it's hard to not internalize that as a personal failing. And so that can actually not only hurt the person's self-image even further, but make them reluctant to access treatment again, because there's so much shame there. So what can clients expect to see in a treatment agreement? I thought it would be helpful to review some of the things. I think on our session, we linked to a QR code. So here we can talk through some of the items. Do you all have some ideas before we go into it? Is there anything that would make you worried? Well, this is the example that is in, is this the one in tip 63? I think so. So I understand that buprenorphine is a medication to treat opioid addiction, and it contains the opioid analgesic medication, buprenorphine, and the antagonist drug naloxone in a 4-to-1 ratio. So this treatment agreement explains what the medication is that's being referred to in the treatment agreement. It explains why the naloxone is present. And then some of the things that a client is reviewing is, I agree to keep appointments and let staff know if I'll be unable to show up as scheduled. I agree to report my history and symptoms honestly to my physician, nurses, and counselors involved in my care. I agree to inform the clinic of all the prescription and non-prescription drugs that I'm taking, any alcohol or street drugs I've recently been using, and whether I'm pregnant. I agree to cooperate with urine drug testing and also to self-report essentially prior to urine testing. The next section goes through essentially the risks of receiving a medication like buprenorphine. So it is still an opioid, that taking it continues physical dependence, but that if I were to stop taking buprenorphine after a period of regular use, I would have withdrawal, and that combining buprenorphine with benzodiazepines, other sedating medications, or alcohol has been associated with severe adverse events and even overdose death. So it goes through how the buprenorphine is to be administered under the tongue for it to be dissolved, and that it should not be injected. And that it's important for the client to keep their medication safe, that it's important not to share their medication with anyone else, and especially important to keep it safe and away from children, because there have been unintentional pediatric exposures. So that's the safe storage of the person's medication. It explains that reporting that your medicine is lost or stolen does not mean that you'll receive additional medication in that moment, and that there will be some pill counts as part of receiving the medication, and that the client won't adjust their doses of medication without talking to their prescriber. It goes through that the medication can make you sleepy. And so while you're first beginning buprenorphine, it's important to be, as your body's getting used to it, to not be driving or operating heavy machinery, and that transportation back and forth might be needed. And it recommends some counseling in addition to the medication treatment. So these are some of the main points that are in the treatment agreement. And then it asks the client and the staff to sign. And usually this is just reviewed with the person at the first visit. So any questions or concerns about this example?
Or I'll just make the point that sometimes these treatment agreements can get pretty long. And so being able to, whether you're in the role of a peer support or a nurse navigator, being able to quickly sort of summarize for the patient what exactly they're signing, or having them repeat back sort of their understanding of some of the key parts of this can be helpful in just making sure everyone's on the same page.
Yeah, thank you.
And I think one of the most important things that I read in all of that is that the being honest, because I think when people feel like their provider is being transparent with them, which I know you guys are, and everybody on our resource guide, as we said, has been vetted, that they don't feel like they're going to be judged when they are honest. And so that's something that I think probably, and I'm sure all of our best doctors here with us here today do that. But, like you have to feel comfortable. And that was something that I was really lucky and blessed to have been found a provider that I felt like I could be completely honest with, and there was going to be no judgment and no, like you said, kicked out or whatever it is throughout the whole process. That's just really important to feel like that you can come there. And I used to always say, I just come here to like regurgitate all this stuff to you, and you just take it and then you sort it all out for me, and we put it back in a way that just sounds better. It makes me feel better.
Yes, trust goes a long way. I had, it's just an illustration of, I was reminded yesterday in my primary care clinic about how often people with substance use disorder have negative experiences with the healthcare system. A patient of mine at his previous visit had recently used methamphetamine, and but was seeking care and wanting to get back into care. And a couple months had passed, and he was back in clinic again and just said, thank you for not calling the police. And I was just completely taken aback. I said, why on earth would I have called the police? You were in clinic and I was glad to see you. You weren't feeling well, but you needed medicine, we needed to get you back into care. And he said, well, I was kind of high. I said, well, you weren't being violent or threatening. You just came to the doctor. Why on earth would I call the police? And the fact that, he would even worry that I would do that, to me was very, it was very striking and a good reminder that, that people really have experienced a lot of stigma and in the healthcare system. And so it's important to try to keep that in mind as we try to provide patient-centered care. So the next section is what are best practices to help a client stay in treatment after the first day? So what do you all think?
It's Danielle. I think one of the things that's really important is once you start treatment, being open to hearing the client's experiences, any side effects they may be having, being able to address the side effects, and also being able to address dosage increases if necessary. Not necessarily making patients wait with buprenorphine for extended periods of time before titrating them up to an effective dose.
Yeah, absolutely.
Jamie in the chat says, ensuring a reliable transportation plan, proactively inquiring about potential barriers, including childcare.
Hey, this is Jennifer King. I feel of utmost importance is they have to have a good support system, especially in the home. That really encourages and keeps them participating.
I definitely agree that that is ideal. Sometimes it's not reality for an individual person, and I've had we have a number of examples where people who are experiencing homelessness or other barriers, and they may not have that support in the home, can do very, very well in treatment. And so so I think it's wonderful when people have an extensive support system, but it's not the case for everybody. And so then we try to strengthen the things that, and maybe begin to build, help that client build a support network if they may not have one, and explore the places that that maybe they could use additional services to help them meet their goals.
Some great comments in the chat. Resource education, transport supports from Joy. I think asking patients up front and being proactive about that is great. Amy says scheduling the next appointment before leaving the clinic, huge. And providing an after hours number, or even just the client knowing, even if you don't hear from us, right, you can leave a message and we are going to get back to you during this period of time. Those expectations are huge. And then Natalie mentions earning clients' trust that we are there to help them. And that starts with understanding what their goals and wishes are.
Thanks, Danielle. One of the ways that that we can encourage clients to begin developing some supportive is through community centers like Voices of Hope. There are similar organizations like that offer recovery support. And I think helping clients access those kinds of services is really essential. Sometimes the person's network is very wrapped up in substance use, and it's hard and lonely to sever those ties if that's what's needed to meet that individual person's goals.
Carrie makes a great point about patient education, understanding what's going on in their bodies and their minds, and how to interpret that. I find that a lot of clients coming in initially ask, why am I feeling so depressed or so anxious even after stopping use? And that's an opportunity to discuss sort of what's been going on in their brain during active addiction and how it can take a little bit. And sometimes it can be helpful to start medication specifically targeting those mood symptoms that they're dealing with, or sleep issues that they're struggling with as well.
What does the patient's first day look like during COVID? Gosh, I hope we can be done with this question soon. Are urine screenings and labs necessary to start treatment? So the short answer is no, but it is important soon in treatment to have objective evidence that supports your clinical assessment from taking a history. So during the parts of COVID that it was very unclear how we could see people in person at all, we definitely did telehealth inductions. We maintained people in treatment via telehealth, and that was invaluable. It was so essential to be able to provide that service for people. And the lab testing is, to me, is probably less important than you doing a meeting face-to-face, doing a physical exam, and having urine testing, being able to, assess withdrawal with the patient. But it should not be a barrier or a hard and fast rule in terms of getting someone started on life-saving medications. So if I've started somebody remotely, then I like to try to bring them in the next couple of weeks, make sure everything's going well, that the medicine is being taken appropriately, and that, we're not under or overdosing, for example. I don't know, Devin, do you have some thoughts here?
Yeah, I think you're absolutely right. Just sort of setting up clear expectations of when you need those things, and generally within the first week or so is what I'm looking for. But you can do a COWS over telehealth pretty well. You can't hit all the things on there. And you can look at their PDMP or their Casper report, or you can look if they were in the emergency department, a week or so ago, what was present in their urine at that time. So all those things can be taken together with clinical judgment to say, this patient is at extremely high risk for overdose and death without initiation of medications for opioid use disorder. We want to do so safely, but we don't want to wait for those additional labs or urine to come back when there's clear evidence that they have an opioid use disorder and that they're a good candidate to initiate buprenorphine.
Yeah, that's a really good point. We may have data from other time points within the healthcare system that is really helpful to use. If somebody's been in the ER with a recent overdose, then things are pretty clear.
Several times I've had patients who are further afield actually go to a local clinic or urgent care and get a test there and have them fax it over. Of course, you need a list of information because you're trying to respect their privacy and be in line with HIPAA laws. But that can be helpful for people who maybe have transportation barriers at that 30 or 45-minute drive, but not at the 5 or 10-minute drive level.
Yes. And we do that anyway for people that may be coming a good distance to receive treatment. We may be able to do random urine testing or random pill counts in a lab or in our pharmacy close to their home to minimize the number of times that people have to drive to clinic. Any other questions about this one? I'm grateful that COVID kind of forced us to move into the telehealth space because I think it's not going to go away, and it's a really, in the future, we're still going to have snow and ice storms, and it's going to mess up clinic, and someone's car may break down. And so it's really it's really nice to be able to ensure that continuity of care. It's unfortunate that it took COVID to break us through that threshold, but any other questions that come to mind generally or patient's first day?
I have a question about the 12-step community working with clinicians. I've been talking to some people who either get sponsorship or are sponsors. And a lot of times the sponsors are constantly asking, when are you tapering, or what's your plan, things like that. And then also the sponsors are saying that they don't know how to blend the two. And I'm not sure how to direct them, like what information would be best for them to figure out how to support someone in MAT, like if we were going to build a training or something.
I think I think that a training would be a good idea. One option is to, invite the sponsor to come to a clinic appointment if that's something that the client was on board with, so that there could be a conversation in person about the benefits of medications and the risks of tapering and early tapering and aggressive tapering. The other thing for me is I'd want to understand more from the sponsor's perspective where those questions are coming from. Is it, and what is the sponsor's understanding of medication and the treatment of opioid use disorder?
Yeah, I'm not exactly sure what the holdup is, but they said that they would be a lot more open to it if they knew how to blend the two. So I'm kind of starting from scratch on this one, and I'll probably have to just like interview and ask more questions, but it seems like they're open-minded. They just maybe don't know enough about it in general. And some of these are even people who work in like community support centers. So they see people on MAT, but maybe they just don't know about the timeline or when it's appropriate for someone to stay on, long-term versus short-term. And I think they understand that they're not doctors, but there's the question of like, what is recovery? And then what is the process for MAT, I guess, is where it's coming from. But that's a great idea about having them come to a clinic appointment at, if the sponsee is okay with that.
So that's, that perception is not uncommon in the 12-step community. And I think it's just part of a slow ongoing conversation to try to change that stigma about medication. Being on medication and not using other opioids is abstinent. So I think we have to remove the perception that taking medication means that you're not abstinent, because that's then that kind of feeds into the cycle of, well, then you're not really in recovery. But if someone is, all those symptoms of opioid use disorder are in remission and they're able to meet their goals and keep a job, take care of kids, whatever their goals are, then taking a medicine every day it's hard for me to understand how that's a problem, but that seems to be the root of it.
I agree with Dr. Fanucchi. It's a cultural issue in a lot of the 12-step programs, and it's going to take a long time to exact change. And I have this discussion multiple times a week, every week, with patients, clients I'm seeing. And what I really, since we can't change the culture tomorrow, one thing I tried to discuss with them is that reinforcing that we view this as a chronic medical condition, kind of like Dr. Fanucchi was saying, a medication that you take every day for a medical problem, reinforcing it as addiction being a brain disease, a chronic medical problem, and really trying to normalize that. We may not be able to change everyone's mind. We may not be able to change the sponsor's mind, but providing reassurance to your client can be really helpful, I think, in this situation, even if you have to provide reassurance every week for some time period.
I'd like to address that from a personal perspective, Ken, here. Having been around Narcotics Anonymous for the last 16, 17 years and clean for the last 14, I've sponsored a lot of people, and my sponsor is actually at 33 years clean. What I didn't know and what they don't know is the science behind this. What they don't know is the statistics behind, bringing somebody, detoxing somebody down to nothing and then turning them loose, and 17 to 20% are going to relapse within the first 60 to 90 days. They don't know that. I didn't know that. Learning the science behind this thing has changed my entire perspective, completely entire perspective. And then, and we're talking with people that are, that are kind of the main leaders in the state and around the nation and so forth. They don't know, and they're curious. One of the things that I was going to ask, and maybe was going to do that in private by email with either Dr. Euler or somebody, was that how can we put together a kind of a small presentation, bringing out, because, I went through a lot of the stuff, but I was in the thing with the Boyle County, and being able to take some important things about this and being able to gin down the thought and the idea, kind of basing it around, okay, diabetes, you may have to take medication for the rest of your life. You may not have to if you get healthy in other ways, but you may have to for the rest of your life. And that's what the disease of addiction is, especially with opiates. And being able to equate that to something that I knew and that they know, that's a tough thing to do. And that's something I'd really like to pursue, getting something very concise, but exactly medically correct, which is what I would not be able to do with the experience I have. But certainly, with the group of people here and with, my mentor and so forth, I think that makes a huge difference, because when I talked to my guy about this, and I said, let me just tell you what I've learned. And we spent hours. The bottom line is that he's coming around on it, but he says, Tom, I was in California when Narcotics Anonymous started. And he says, how do we say that what they did wasn't right? I said, Bill, we don't know. They didn't know. There's new science on this. There's new medications on this. So we had about a 2-hour conversation on that, and we're going to continue to have those conversations more and more. But he doesn't know how to break tradition, because in the 12-step groups, tradition is a way of getting people going the same direction at once. You have the 12 steps, you have the 12 traditions. So I don't know, but for me, I'd love some help on that. Thank you.
Tom, thanks for sharing. Feel free to email me. I've spoken with some 12-step groups in the past, and happy to be. I don't know if I would call myself an expert in navigating both medication and the mutual aid organizations like that. But again, happy to chat. And I think Joy makes a really good point in the chat as well, is there are emerging and growing a lot of groups that get it. Right. And whether it's more anonymous, whether it's smart recovery meetings. So, immediately what you can do with clients is nudge them in that direction, so that they just hear all those perspectives and can decide for themselves, they're adults, about sort of what's going to help and support them the most.
I agree. Thank you.